Thanks very much for the introduction and for the invitation to be here today. So I'm I'm the light relief from cognitive remediation because I'm not an expert in cognitive remediation at all. I'm going to be talking more broadly about how we might deliver what we refer to as a whole system approach to mental health rehabilitation. So first of all, what do we mean by rehabilitation and who needs it? Well, we're basically talking about people who have particularly complex mental health problems. Most of these people will have a primary diagnosis of psychosis with symptoms that haven't responded well to first or second or even third line treatments. And we're talking about positive and negative symptoms. Of course, we're talking about cognitive impairments about which this expert audience know a great deal, but also coexisting problems that might predate the development of the psychosis and coexisting problems that complicate recovery further. All of these things come together into a kind of what I refer to as a confluence of complexity that really impact very negatively on the person's ability to manage everyday life and leave them very highly vulnerable to self-neglect and to exploitation from others. And because of that, what tends to happen to this group is that they end up in some kind of institution, either spending a very long period of time in hospital, not being able to be discharged, recurrently hospitalized. And when they leave hospital, they often have very high community support needs. And because of that, they tend to cost a lot. And in fact, it's been estimated that this relatively small group of people, compared to all of those with mental health problems, absorb somewhere around half the total spend on mental health when you add up health and social care costs. And this group is a group which continues to come through the system. So we know now from longer term studies of early intervention for psychosis, cohort studies, that around 20%, somewhere around 20-25% of people who are developing a psychosis will go on to have these kinds of complex problems. We've come through a period of deinstitutionalization in many countries where we figured that if we could get most people out into the community, we would be able to prevent people needing very high levels of support and having long-term hospitalizations. And actually what we're finding is that that isn't the case, that in fact this group continue to come through the system. So in the UK, services for this group are referred to generally as mental health rehabilitation services, and they tend to be organised into what we refer to as a care pathway. And that quote at the top of the slide on the left is a definition of what we mean by mental health rehabilitation. Although it's got my name against it, it's not my definition. It was a collation of mental health rehabilitation practitioners' thoughts about what rehabilitation is. And the key things really are that it's a whole system approach which is supporting people to recover, to achieve their optimum level of independence and to be able to live successfully in the community. And that whole system approach is really important because it's easy to think of rehabilitation as being about being in a rehabilitation ward or a rehabilitation centre, as though it's something which you can kind of do to somebody, then they'll be better and be able to get on with life. And that simply isn't true. We need a whole system of supports from health and social care, from statutory and non-statutory providers working together to support people through the processes of recovery. Now, you see on the bubble on the left-hand side of the slide there that the majority of people will come into an inpatient rehabilitation setting in the UK from an acute admission ward. About 80% enter from an acute admission. And about 20% come directly from our forensic services. So rehabilitation pathways are really important as an exit route for people leaving forensic care. We have different forms of inpatient and community-based rehabilitation unit in the UK where people will have specialist rehabilitation interventions and then move on to the community, usually to some form of supported accommodation. And there's then a process of people graduating, stepping down from higher to lower levels of support over time, with the clinical input in the community being provided by specialist community rehabilitation teams. If you're lucky, about a half of the NHS organisations in England have a specialist community rehabilitation team to do that, or from another more generic multidisciplinary community-based team, and physical healthcare being provided and through close liaison with primary care. Now, the things that go on in inpatient and community-based rehabilitation settings have been described in this document, which is called the Joint Commissioning Panel Guidance for Commissioners of Rehabilitation Services. So a lot of what I'm talking about is expanded on in that document if people are particularly interested. But in a nutshell, we're talking about requiring a multidisciplinary team to bring a biopsychosocial cultural approach to support people's recovery. That involves getting the medication right. Often we're getting into quite complex medication regimes, and then we need to deal with complex side effects from complex medication regimes. So you need people who are expert in managing medication like that. Physical health issues that need to be approached. So these are all the sort of the medical parts of the MDT. There's a huge role for occupational therapists because the work is often, in the majority, about function. It's about helping people gain the skills and confidence to be able to live successfully in the community outside of hospital type settings. And so occupational therapists are absolutely crucial. That's not in any way to undermine or undervalue psychologists, who also have a key role, of course, in delivering evidence-based psychological and psychosocial interventions, also providing supervision for other members of the team, and very importantly, providing a space for reflective practice. When you're dealing with people who have very complex needs, it's very easy for teams to get frustrated, potentially to get burnt out and to lose therapeutic optimism. And one of the key facets of mental health rehabilitation, a key cultural paradigm, is that these teams really need to be optimistic. They need to hold hope for people's recovery. You'll find that a lot of people who come into mental health rehabilitation services have spent a long time in other bits of the system. Other parts of the system may have lost hope for their recovery. People may have become estranged from their families because of their complex needs. And so building bridges with family and other support networks is another important part of this process. Now, these teams also need to hold the long-term view because change tends to happen rather slowly for this group. And that long-term view is also reflected in the time frame around this pathway. So on average, we know that people will have spent about 10 years or more in touch with mental health services before they get into a rehabilitation pathway. Now, that's far too long with recurrent admissions, and we need to do something about identifying people much sooner who need these kinds of specialist services. Once they get into the specialist inpatient or community-based rehabilitation part of the pathway, they might be there for somewhere between 1 and 3 years. So it's potentially a long and potentially expensive intervention. And then in supported accommodation, we're talking a number of years as people graduate through this system towards greater and greater independence, maybe 5 years, maybe longer. However, when you have that kind of pathway in place, what we do know is that most people will do well. And we know this because although we can't do randomized control trials of mental health rehabilitation, what we can do are case control studies and cohort studies. And this case control study from Ireland looked at what happened to people who had access to this kind of system and people who are on a waiting list for it. And what we found was that people who had access were 8 times more likely to be successfully supported to be able to live in the community without readmission and without their placement in the community breaking down. And they also had more improvements in social and everyday functioning than people on the waiting list. And we've carried out 2 very large programs of research across England looking at this whole rehabilitation pathway, the first of which focused on the inpatient rehabilitation component. And what we found is that 57% of people were successfully discharged from inpatient or community-based rehabilitation units into supported accommodation without things going wrong, without the person needing readmission or the placement breaking down within about 2 years of coming into the pathway. And another 14% could have been, but were waiting for a place in supported accommodation. So there were delayed discharges. And if you add that together, that gives you a figure of around 70% doing well, so about 2/3. The second programme included a big cohort study looking at supported accommodation. And here we found that 38% of people progressed from higher to lower supported accommodation over 2.5 years. And that was rather a magic time frame, because many of these services in England are commissioned to work with people for around 2 years. That figure was just kind of made up by policymakers. And what we've shown is that most people do not manage to move on within 2 years. And so that figure needs to be adjusted. A much smaller cohort study, just in North London, in the area that I work in, looked at people over 5 years, and this 2/3 figure came up again. 67% sustained successful community discharge over 5 years. But importantly, only 10% of people managed to get to sort of the end of the pathway, where they were living completely independently in a permanent tenancy without needing additional supported accommodation staff. So that means that 90% of this group will continue to need support in the community. Now, those big cohort studies have allowed us to look at predictors of moving forwards in that pathway, so predictors of better outcomes for this complex psychosis group. And those of you who are keen-eyed will notice that these are very small odds ratios, but they do give us signals of the kinds of things that we need to be focusing on in these settings. So people who had higher levels of social skills, who were more engaged in activities, and in services that had a greater recovery orientation, tended to have better outcomes to move forwards along the pathway. And in the QUEST programme, the one looking at supported accommodation, again, the recovery orientation of the service was a driver of better outcomes, but so was the promotion of people's human rights. And we assess those two domains, the recovery orientation domain and the human rights domain, using a standardized measure called the QUIRC, the Quality Indicator for Rehabilitative Care. This was a measure that we developed through a previous pan-European study. There's also a version for supported accommodation, and it assesses the quality of care provided in mental health, rehabilitation, inpatient and community-based facilities, and in supported accommodation facilities. And it gives you ratings on 7 domains. These are 2 of the 7 domains, but it also assesses the interventions, the built environment, the degree to which the service promotes people's autonomy, and other domains. And you can see that in the recovery orientation domain, as well as therapeutic optimism, which I've mentioned already, another important part of this is having an expected maximum length of stay, so that the service is aware that they're trying to work with somebody for a defined period of time, and that allows them and the service user to be clear what might be achievable within that period of time. And we found that in services that don't have any particular length of stay associated with them, things can really grind to a halt. People become very unclear as to what the purpose of that service is, and it can easily become something which feels much more like a kind of residential care home rather than a therapeutic treatment centre. The recovery orientation domain also picks up on something that Alice was talking about, needing a lot of collaborative and individualised care planning is a key part of these recovery-oriented services, and building on people's strengths rather than focusing only on deficits, starting from people's strengths, using that as the place to build once you've identified the particular areas that somebody needs support with. Now, we are really in need of a very good health economic analysis of mental health rehabilitation services, and there are 2 underway, but neither are yet published. The only one that we have that has been published is more of a cost-benefit analysis, looking at the costs of people who came into a rehabilitation service in Greenwich, just outside London. In this study, the costs of people's inpatient care were totted up for the 2 years before they came into the rehabilitation service, during the rehabilitation, and for the 2 years after. And you can see that they drop from £66,000 per year before rehab down to £18,000 after rehab. So there's a big impact in terms of reducing inpatient stays, but the cost of rehab is quite a lot, £74,000 a year. So you have to be able to really justify investment in these kinds of programs. But if you just bear with me and allow us to extrapolate those figures, to make the maths easy, we'll extrapolate them on the basis of 100 people, and we'll think about a trajectory similar to the one I've shown you of around 10 years. So if we take 3 years before rehab, 2 years in rehab, and 5 years afterwards, and you just extrapolate all of those numbers up on the assumption that 67% are going to do well, the total costs then come down to about £52 million, with rehab in place. And that's assuming that the 33% who don't do well never leave hospital, which is very unlikely. In fact, most people will leave hospital. A very, very tiny number won't. But the total cost, if you don't have rehab in place, is of course £66 million. So we can make these kinds of very rough estimates to try and justify the case, but we really do need more elegant health economic studies. What we have also found, though, is that staff morale in mental health rehabilitation services is pretty good. These data come from a national survey of staff morale in different parts of the mental health system across England, and we also replicated this in supported accommodation services. And what they show is that scores on the Maslach burnout inventory and total burnout are lower for people who are working in rehabilitation and supported accommodation services compared to other bits of the system. And when you talk to people who work in rehabilitation settings, they often say that they love working in rehabilitation because they have time to work with people, that people are there for a while, they're able to build rapport, they're able to actually do the work that they wanted to do when they came into a mental health profession to begin with, something which has been undermined by very, very short lengths of stay in other parts of the system. So despite this pretty good evidence, what we're actually finding in the UK is that there's been a lot of reduction in investment in NHS mental health rehabilitation services across the UK. Since 2003, 61% of inpatient rehabilitation services have reported some form of disinvestment. About half of them have actually been closed. There's been a shift in investing in supported accommodation and community teams providing the clinical input into supported accommodation. And there's also been an increase in the implementation of community rehabilitation teams, as I mentioned earlier. So all of that is sort of potentially good. We're trying to do more in the community and less in inpatient settings. But there is a problem with that, which is that we're finding actually that it's not picking up everybody who needs these kinds of services. And in fact, the Care Quality Commission, who are the hospital inspectorate for England and Wales, they go around seeing all of the inpatient and equivalent facilities across the country on a regular basis to assess quality of care. They became very worried about the high number of people they were finding in so-called locked rehabilitation wards. This is not a term that has been defined. It's not a term that anybody working in rehabilitation policy has ever suggested should be used. But these units have kind of cropped up a lot across the country, often a long way from the person's home, often provided by the independent sector. So it seems as though a market force is at play, that with the reduction of NHS inpatient rehabilitation services, the private sector has just stepped in to fill the gap. And the Care Quality Commission were very worried about the quality of care in some of these settings, with many not employing appropriate multidisciplinary staff to deliver the evidence-based interventions that they should be delivering. And in fact, they went as far as to say that they felt that these units were institutionalizing people rather than being in any way rehabilitative. In total, there are 5,000 rehabilitation beds across England and Wales. Over half now are provided by the private sector, and the total cost per year is about £500 million. The length of stay and the cost of care in those private sector units is exactly twice that of an NHS rehabilitation unit. So this is a very poor use of public money. And this has been picked up by the BMA and by other mainstream newspapers. So that's the situation in the UK. This data here comes from a survey of 25 European countries by the WHO, looking at the quality of care in longer-term facilities. And what you find here is rather depressing news that across these kinds of longer-term facilities, again, very poor quality of care, a lack of knowledge about mental health. This is staff not having much knowledge about mental health and about people's need for protection of their human rights, lack of personalised approaches, lack of rehabilitation, etc., etc. And whilst many of these countries, you could say, well, they're at an early stage of developing community-based care, actually the ones I've highlighted in purple are not. And they're also higher income countries who should simply be doing better. Even in countries that have been at the forefront of deinstitutionalisation, Italy here, we're finding this move towards reinstitutionalisation of people with longer term and more complex needs. So this is data from a survey in Lombardy where there are a lot of so-called community residences, which are kind of group-supported accommodation facilities. Residential care homes is what we would probably call them in the UK. And there's been a big expansion of these in the last decade, and again, very many concerns about a lack of rehabilitative ethos in those settings. And seen here in Australia, there's a big focus as well on the quality of care for people with more longer term needs. Again, a country with few inpatient services and increasingly a role of partnership with NGOs to provide longer term based care. Very complicated system for funding care, particularly for those with longer term problems. And these data from the SHIP survey suggest that there's suboptimal treatment going on. People not getting the right medications, not getting the right access to psychosocial interventions or physical health care. And then just to top it all, the welfare benefit systems can also add to the problems. This report in The Guardian came out recently that showed that a recent change to the disability living allowance, which is a welfare benefit for people with complex health, physical and mental health needs, had really disadvantaged those with longer term mental health problems, with about people with mental health problems being 2.5 times more likely than those with physical health problems to lose their benefits. And then I won't even go into the NDIS because I know that you are the experts about that and not me. So that's all a bit of a pessimistic story. So we need to think about, well, how do we turn that around? And I think that there are a number of drivers for delivering appropriate services for people with more complex needs. So first of all, we need supportive policy, and I'll say a little bit more about that in a second. Secondly, we need guidelines. Now, guidelines are things that sometimes just sit on a shelf and nobody reads, but they do have quite a lot of clout. In the UK, we have a system of commissioning. So there are service commissioners who decide what services are going to exist in a locality. And those commissioners are accountable for commissioning the services that are recommended by NICE, the National Institute for Health and Social Care Excellence. And then the service providers are responsible for delivering those things that are recommended in those guidelines. And they can be challenged, both the commissioners and the providers can be challenged if they're not doing so by service users, by families, and by professional bodies. So it's really worth having things in clinical guidance. I'll say a little bit more about where we're at with guidelines in a second on this. There are also some things that we need to think about around service planning principles for this group. I think it's very important that people who have very complex mental health needs are able to receive and access appropriate rehabilitation services as close to home as possible. So, I mean, I know being local means something different in the UK than it does in Australia, but we still need to think about the ways in which we can maximise people's access to services and try to keep them as close to home as possible. Planners need to think about long-term service planning for this group. We know it takes many years. We know that a lot of people are going to need support over a very long period of time, and yet service planners often work to an annual financial cycle. And so they're often not thinking about pathways that support people over a decade or so. So that needs to shift. And then we have lots of potentially perverse incentives for providers financially and structurally that get in the way of being able to put these systems in place. We need to be able to integrate these different components of the whole system, the health, the social care, and the voluntary sector more successfully. So I will just talk very briefly about each of these. First of all, policy. Well, in recent years, policy has tended to have more of a focus on public mental health promotion and early intervention. Nothing wrong with that in itself, but it has somehow managed to miss out the needs of people with more complex problems. Many of the things that lead to more complex problems may well not be amenable to early intervention or public mental health strategies. And in fact, we've known what those things are for many decades. So this group have sort of been missed out of policy, and that has been highly detrimental and led to these kinds of closures of services. There's a little bit of hope on the horizon. Our most recent health policy in the UK is called the NHS long-term plan, and it actually mentions the word rehabilitation. So that's the first mention of rehabilitation we've had in about 15 years, so that's positive. But it also specifically talks about maintaining and developing new services for people with the most complex needs. So that suggests that we might have some angle now on preventing further closures of services, as well as potentially developing newer services. The first NICE guideline for mental health rehabilitation is due for publication this year. This has been a 2-year piece of work. It's at the moment in consultation and in the process of responding to the consultation. And so I can't tell you what's in it, I'm afraid, because it's not officially published yet. I can tell you what it covers roughly. You can see what's in scope. We're talking about people who have a primary diagnosis of psychosis with severe symptoms that are likely to have not responded well, with comorbidities and impaired function. So it's that group that this guideline is particularly focusing on. Out of scope are people who don't have a primary diagnosis of psychosis, but that doesn't mean that people who have comorbidities of other mental health problems cannot be included, as long as psychosis is the primary issue. And it covers a range of areas. First of all, the evidence around identifying people who are likely to benefit from rehabilitation. So trying to get at that issue that we've identified, that people do not access rehabilitation early enough, that they're in services for 10 years before they get into these specialist systems. There's a lot in there about the way that services might want to think about organising themselves to provide supportive pathways for people in the longer term, and the components of care required for that, including community and inpatient settings, community teams and supported accommodation. There's a lot about delivering optimised treatments. So this is going beyond the other NICE guidance on, for example, the treatment of schizophrenia. What do we need above and beyond that for people who are not responding to those sorts of first and second line treatments? Collaborative care planning and service user and carer experience are really headlined in these guidelines, because it's so vital, this aspect in terms of recovery orientation. And then there's a lot about the evidence for therapeutic programs specific to rehabilitation, which is a lot about activities of daily living, vocational rehabilitation, interpersonal skills, and physical health care, and things that are going to promote physical health outcomes. We've also talked about different types of supported accommodation, and finally about transitions out of rehabilitation services into other parts of the mental health system. So just a note on service planning. We have to be very careful about market forces. I've already alluded to this problem. If you cut a part of the system out, the private sector can very quickly step in. And what we've found in the UK is that as the numbers of longer-term facilities have reduced since the 1970s, that's the sort of green bars in this chart here, the number of similar facilities provided by the private sector has far outstripped where we began. That's the blue line at the top there. So there are a huge number of private sector providers in the UK. I think it's very easy when you're the manager of a service or the senior manager of a system who's facing a lot of pressure to cut budgets to think, well, we'll cut the rehabilitation unit. It's an expensive part of the system. We'll just get rid of it. And that brings us in on the bottom line this year. And that is a false economy, because it will get shifted into this other part of the system. The procurement cycles for different components of this pathway are very unhelpful. In our particular system where I work, the supported accommodation services have to reapply for their contracts every 2 years. So every 2 years we have a change of provider, a change of staff. You can imagine what that does to continuity and rapport building with people with complex needs. It's really very unhelpful. And it's also the case that sometimes we just get caught into fashions that sometimes everybody thinks that we can do all of this stuff that we're doing in rehabilitation outside of hospital settings, and that feeds into cutting the inpatient part of the pathway. Actually, we need both. We need a balanced model, and we've known that for many years. If you are familiar with the work of Graham Thornycroft and Michelle Tansella, we need a balanced care model of mental health provision. Just the fourth component of this is about integrating, trying to bring the health and social care and third sector together. There's a new fashion at the moment in England called integrated care systems. To be honest, nobody quite knows what that means, but it's something to do with bringing everything together. The aim is to try and think locally and to think about what you need locally and to try and bring all of your resources and providers into a local system. That sounds quite good. In fact, mental health services are fairly advanced in that kind of thinking compared to other parts of the health system. The idea is that you all have a shared vision, you sign up to a joint strategy, et cetera, and that you share some financial risk. So those things can work terribly well, particularly when you're thinking about people with longer term needs. But the devil's in the detail. There isn't really any detail as yet. It really boils down to what the remit is of each of the particular components and exactly who's doing what. And in order to really make that work, it can probably turn out to be quite resource heavy because you need to have an awful lot of interface meetings to be sure that you're all still pulling in the right direction. So here's just one example of an integrated rehabilitation service model. This is, I don't know if anyone's visited King's Cross in London recently, but it's an area that used to be really awful. It was the place that you got out of as soon as you could. It was quite an edgy place, really poor, lots of drug dealing, etc. And it was not a nice area. It's been completely redeveloped and it's all really beautiful now. And there's some extremely expensive housing developments. And a third sector provider has built a really beautiful 24-hour supported apartment block for people with severe and complex mental health needs there. It's called Tile House. And at the time, it's been up for about 9 years now, but at the time it was really quite innovative to have this partnership between statutory and non-statutory services working so closely together in the same building. So there are 12 one-bedroom flats. The clients have their tenancies for those apartments and they pay their rent through housing benefit. The building and the support staff are provided by the housing association, and the clinical staff who sit in the building are provided by the local NHS organisation and continue to be employed by that organisation, which protects their pension and employment rights. And this has been much lauded as the way forward, that this is a really good use of pulling the different components of care together. But there are pros and cons. It does promote common values and common language, and it allows you to use the complementary skills of support staff and clinical staff. You certainly learn from each other, and it's possible to have a more collaborative approach when you're thinking about the ways in which you might be able to support service users with everyday activities and with their longer term plans. It certainly allowed us to get some people out of hospital who had spent a very long time as inpatients without them necessarily needing to go back in. And it was part funded, in fact, by pulling some people out of the private sector who had got stuck in these out-of-area private sector places. It's not that clear, though, whether it's truly economically efficient. But at the time, that was certainly one of the drivers for it being set up. Some of the challenges, though, are that when you've got these two sort of parties working together, you can get into some difficult conversations about who decides who gets a place there. And so who ultimately is the decision maker around who comes into that service has been one of the sticking points. There can also be tensions between support staff and clinicians in many aspects of care. One of them, though, that tends to cause the most worry is around how you respond to challenging behaviours. There can be tensions in understanding the remit of each other's roles, with everybody thinking that whatever it is the other person's job. And there certainly are practical issues, particularly for the clinical staff. It took about 5 years to be able to get access to the NHS electronic records for the clinical staff based there, and that feels terribly unsafe and is also very time wasting because they had to keep going to another base to make their entries into the notes. And they also complained of feeling quite separated from their usual MDT supports. And in fact, it's quite an expensive model. And although you can easily show that you can save costs by bringing people out of expensive placements into this kind of setup at the beginning, The proof is, does it sustain people over time? And actually what we have found is that there have been quite a lot of negative outcomes of people being readmitted or not being able to move on. So this expensive model then has to be there for a very long time for people. So I'm not suggesting it should necessarily be dismissed, but I think that people had looked at it with rather rose-tinted glasses to begin with. So an alternative approach is that you keep these things separate and you have a community rehabilitation team who provide that clinical specialism, and they are, in our setup, we talk about care coordinating people in these supported accommodation settings. So they hold all the health and social care responsibilities separate to the support staff in the supported accommodation, and they do a lot of in-reach and liaison with all the different facets of the system. And that seems to be working quite well. It allows you to have a lot of contact with service users, the staff, as well as families, and provides opportunities very similar to being co-located in terms of being able to talk about the difficulties and challenges of individuals. And there's a big role as well in terms of liaison with primary care and physical health. So we haven't sorted out the best way of doing this, but these are the two ways that exist across most of England at the moment. So I just concluding with a few points. Delivering this whole system approach to deliver mental health rehabilitation requires, first of all, an acknowledgement of the fact that there is a group of people who have very complex needs, and that's sort of a key and needs to be acknowledged nationally in policy and locally as well. And that then there is this commitment to providing appropriate longer-term services that will support people to progress in their recovery over a number of years. They should include, in my view, both inpatient and community-based services, and these different components of the system working well together. We obviously need appropriately trained and supervised staff who are all working within a recovery orientation, and we need to be hyper-vigilant in order to prevent the systemic failures that lead to reinstitutionalization of this group. Thanks very much for your attention, and just final thing, to hold on to the long-term view. Thank you.